So we're going to talk about BICAR-ICU. Really the first sort of, as far as I'm aware, the first sort of randomised control trial involving bicarb. There's obviously been evidence that persistent acidemia is associated with a poor prognosis, but there's, it's probably fair to say, ongoing debate about whether bicarb does or doesn't have a role in that setting. We obviously have concerns about acidosis reducing response to inotropes, and as you get more acidotic, there being cellular dysfunction. Some people would say bicarb is beneficial in those situations, but there's also concern that actually we might improve some numbers, but actually worsen intracellular acidosis. So the prior research sort of level of evidence, I guess, is probably an absence of high level of evidence. Much of it is retrospective or observational. And what this study talks about in its sort of introduction and justification is, despite that absence of evidence, most surveys suggest that bicarb is used fairly frequently. So their hypothesis, and apologies to put it up there, but it's just easier, was essentially that if they give sodium bicarbonate nice early and compared it to people who didn't receive it, they hypothesized that they would see fewer deaths and a lower incidence of at least one organ failure at 7 days in people in ICU in severe metabolic acidosis. So we'll go into the groups as we come to it, but clearly there's going to be a control group that didn't receive bicarb and a bicarbonate group that received it. So this was a study done in France. It was done in 26 ICUs. It was open label, so both the health providers and I guess patients were aware, but obviously most of the patients wouldn't have been aware, but importantly, doctors and nurses were aware, and the justification of that was clearly the fact that the bicarb would raise the bicarb on the blood gases, and they felt they couldn't really blind to that, albeit the people collecting the data down the line were obviously not necessarily aware which they had received. It was randomized, it was computer generated one-to-one randomization. They did pre-specify groups that they were going to sort of randomize within, and there was age greater than 65, whether the presence or absence of sepsis, and then ACIN, which is actually one of their kidney scores, sort of stage 2 or 3 being present. So these subgroups were not just post hoc afterwards, they were set out beforehand. And it's a phase 3 trial, and more from my revision, that is just to remind me that that's obviously exploring the, as it says there, the safety and effectiveness of a treatment compared to other treatments. So if we look at the selection sort of criteria, you had to be within 48 hours of your admission, you had to be over 18, and what they looked for was someone whose pH was less than 7.2, not driven by a respiratory component, and obviously with a low bicarb. In addition to that, and they had to either have a SOFA sort of severity score greater than 4 or an arterial lactate greater than 2. So the first point, and I'll just, rather than maybe having a strengths and weaknesses sort of table at the end, we'll just chat about things as they go. So obviously what they haven't done there is massively specify about the type of metabolic acidosis. There are some exclusions. So respiratory acidosis is obviously excluded. They excluded anyone with a digestive or sort of urinary tract known bicarbonate loss. So yeah, reasonably that will presumably be a lot of sort of non-anion gap acidosis. CKD stage 4 and also ketoacidosis was not there. But as I say, there's no, in the results, there's no sort of what proportion of what acidosis or different types there were. And you know, that's important when we come to see how we can or can't apply for that. You also couldn't have had, you know, sodium bicarb in the 24 hours before screening. And we'll come on to that in a little bit. So if we look at the different groups, then there's obviously the control group. They they literally are a control group. They receive nothing. There's no equivalent fluid because it's not a blinded study. And as we'll come to the outcomes, they did look at fluid balance difference because obviously they are giving fluid to the bicarb group. And what they did was they used 4.2% sodium bicarb, and their protocol was basically that they were aiming for a pH greater than 7.3. So if your pH was less than 7.2 and you got enrolled into the study and in the bicarb group, then you would get between 125 to 200 mils of 4.2% bicarb over half an hour. You'd repeat a blood gas 1 to 4 hours later, and if your pH was still less than 7.3, then you would get another round of bicarb, and they'd continue that within a 24-hour period until you'd had 1 litre of 4.2% or your pH was greater than 7.3. So there's a few things to sort of say about that, really. And just to point out, this is over 28 days or till the point you discharge from ITU. Now, obviously, I've never worked in a unit that's got 4.2%, so that's immediately relevant to us. They also, there's no calculation in terms of, they haven't calculated how much bicarb they think they will need to achieve this, and so how you can take that and use that if you've got other bicarb is one of the things that we just need to think about. It was done on intention to treat, which is obviously always good, so no moving between groups. And the other thing that obviously comes with acidotic patients and bicarb is there were recommendations for when to use renal replacement therapy. So on admission, they said if you're hyperkalemic with ECG or you've got pulmonary edema, then obviously they strongly recommend it. And then for the rest of the study, essentially at 24 hours or beyond, if you had 2 of these 3, which were relatively low urine output, a persistent acidosis despite resuscitation, or you were hyperkalemic, then they would strongly recommend that you use renal replacement therapy. That renal replacement therapy was obviously whatever you've got locally, and they don't go in any more than that. We'll obviously look at who got that, but this is relevant because there's a lot of people are receiving bicarb and replacement when they're on renal replacement. So again, it can cause some sort of noise between the groups, if you will. So if we come on to outcomes, then the first thing to say about this study is its primary outcome is actually I can't say that. I'm going to assume that says composite. Yes, brilliant, good. So now that immediately, and for those, and I include myself at the top of that list who are less familiar with that term, that's obviously where they use they look at several different sort of outcomes and merge them into one entity, if you will. And what they looked at was death by any cause by day 28, or the presence of at least 1 organ failure at day 7. Now, the pros of using a composite is that it's sort of almost statistically efficient in the sense that it's maybe easier to show a significance. You maybe need less patients, a bit less time, might be more cost effective. But it also is one of those sort of markers that sometimes you need to look at when you're looking at a paper, because it can make something seem more effective. And the other issue here is you might get a positive outcome, but of course, is that more led by the presence of an organ failure, or is that more led by death? This paper is not so much an issue because it does separate out individually each one, but you just have to be aware of it. And then the other thing that comes to mind, and I'm not the most statistically minded of people, but if it's powered to a primary composite, how does that marry up for the individuals? So you just have to have that in the back of our head. There were numerous secondary outcomes, so SOFA scores on different days, adverse electrolytes, obviously looking at, did you get, what was your potassium, was it high or low? Sodium, because obviously we're giving that. They looked at acquired infections, length of stay, sort of life support interventions, particularly RRT is going to be important in that. And as I say, they also looked at fluid balance, and that's important, particularly moving on from the different groups getting bicarb or not. Just coming to the powered, and what they've got is that they needed about 376 patients, and that was basically saying that they'd have 80% sort of stats power to show a difference of 15% in that primary outcome. Now, I suppose the first thing to say that mortality, and there's lots of talk, I think, about whether mortality is a good marker or not, and there's different issues in this. So one, it's a heterogeneous measure. So we're using BICAR, but we're measuring all-cause mortality. And if you die of one thing or the other, is that linked to your acidosis? So it's very wide. Also, some people argue, well, over time mortality is reducing, but of course we use sort of often older evidence to power our papers. So if mortality was higher then, but we're getting the numbers we need from that paper, then often we can end up with studies that are underpowered. And then the other argument for my sort of simple mind is they sort of split ITU patients into 3 different types of patients. You've got people that are likely to die, people that are really unlikely to die, and then people that are maybe more borderline. And so actually the borderline people, you might make an impact, but the rest is quite noise. And again, it's potentially quite difficult to show a positive effect on mortality. For completeness, the sort of the two-sided alpha level is 0.03, and in my head 0.025 is what I normally think of, and in the sense that we think of p-values of 0.05, and it's half that. So that just catches my eye. Let's look at the patients then. This is their flow diagram, and we'll just make it larger. So the first thing to say here is they've looked at 942 patients, but only 400 were then assigned. Lots of different reasons why, and that immediately also makes you realise that you've got to be very careful about where you're applying this to. And we saw the inclusion criteria. We saw the fact that this is not looking at ketoacidosis. It's not looking at certainly some forms of non-raised anion gap, but we don't know what proportion the acidosis were. But the really important one here, I think, to highlight is that 109 people had already received sodium bicarb before they randomized these patients. And actually, there's 400 patients assigned, so that's a significant proportion. And presumably 109 people were given sodium bicarb because people thought they're really sick, they really need it, but you've almost self-selected a population out that may or may not be less or more likely to respond. So that is relevant in that sense. So if we look at the implementation, then there was good group separation. They were well-balanced groups. Their baseline bicarb, I think, was actually virtually identical. And if we look at the pH difference, there was a significant pH reach difference between the groups. So 26% of the control groups actually reached what we would call the target pH. Now, of course, that might just mean they got better. We weren't giving them bicarb to do that. 60% of the bicarb group reached it, and I don't think it necessarily matters. You need a separation between the groups, and this is obviously statistically significant. Like there was a difference in their pH, but whether they reached that 7.3, I don't think necessarily matters. That's just picked as a target. 99% of the bicarb group received bicarbonate, so clear that's good. But one of the issues and one of the real points is that actually 24% of the control group received sodium bicarbonate. So clearly really diluting your ability again to show a positive difference between these groups. And 52%, and we'll come on to renal replacement therapy in a minute, but 52% of the control group also received renal replacement. And given that, obviously essence that has bicarb in it, again, you wonder how that's going to muddy the water and lower any effect. One of the other interesting things that's in the discussion is they note that actually, and I can't even remember the exact phrase, but nearly none of their bicarb was actually implemented between 24 to 48 hours. And I think it's, for me, that was a bit of a wake-up call, because when you hear about this study, and I think randomized control study, BICAR-ICU, I think brilliant. This is going to be the patient who's carking it, that I'm pulling out 8.4% and giving it to, and this will tell me about whether that is or actually isn't a good thing. The fact that no one gets it between 24 to 48 just makes me sort of think, is that a load of people who got it in that first 24 hours either got better or got worse and died? And I don't know. And again, it's just a marker of what this study is. And this is a real look at, predominantly, it will include some of those patients that got it in extremis, but it's also this is persistent acidemia in ITU in some very set criteria. So if we look at the start looking at the sort of results then, so 61% of the patients had sepsis, 47% of them had significant sort of renal, the majority were ventilated and on vasopressors. So not unsurprisingly, sick patients, and that fits in with the fact that they're acidotic. If we look at the primary outcomes then, there was no change in the primary composite outcome between the groups. And if we look at them and break them down, there was no change in mortality, and there was no change in organ failure at day 7. And for reasons maybe we've talked about, maybe that's unsurprising. Difficult to show difference in mortality. There was bicarb used. It might be underpowered. However, in one of their sort of predefined strata, they did find that the primary composite outcome, so for patients with renal failure, they did find a difference in the primary outcome, and that was statistically significant. And it was significant in both the mortality, as you can see there. I think those figures, I'm going to check in a second. I think they're the wrong way around, because the bicarb group really had the better mortality. And the one or more organ failure at day 7 again was less in the bicarb group. So there was a suggestion that mortality was better. The only thing here is this is not a post hoc analysis of a subgroup, but it is not the primary patient population, which was all comers. But then they came on to look at the secondary, and they looked. There's lots of things that were not significant. So just to talk about the ones that were, so time to initiation of renal replacement was longer in bicarb. So it was felt that in that group it would delay needing renal replacement. And actually, when they compared the two groups, the bicarb group had less use of renal replacement therapy. And that was again statistically significant, and the number needed to treat for that was 6. So for 6 people they treated, they felt they would there'd be 1 person who didn't need renal replacement therapy. Ultimately, they concluded that in patients with severe metastasis, it had no effect. Bicarb had no effect on the primary composite outcome, but that it did decrease the outcome and day 28 mortality in patients with AKI. So apologies that those figures were the wrong way around. But yeah, so bicarb had a positive effect on your mortality if you had renal impairment. So what to do with that? So some people would say, if you're a purist, I guess, would say that if your primary outcome is negative, then we've got to be wary of other things that we're drawing from this study. This is also the first sort of randomized control study. It's not blind. We need to remember that. And it would clearly be nice to see that validated in other work. The secondary outcomes, and particularly in the sort of using bicarb delays renal replacement, again, that sort of fits with maybe our use. We know, renal physicians will often use bicarb in uremic acidosis. It would fit with our theory, but this is a study that wasn't blinded, so there can easily be bias, like, oh, we're giving bicarb, so we'll delay the renal replacement therapy. So difficult to draw sort of conclusions from that point of view. It's an interesting study in the fact that some people, and reading different people's sort of reviews of it, some people sort of say, oh, I think, you know, it hasn't shown a positive outcome initially. It's generated some, you know, something that clearly has further research that would be useful, but it doesn't change my practice. Other people have sort of said, if you use bicarb, there's probably enough here that suggests I'm not doing harm. There may be some benefit. And if you don't use bicarb, actually, this is probably not saying that you have to use it. And also, I think, unfortunately, at the core of it, we don't have 4.2%. And therefore, it doesn't immediately change, you know, what I do. And probably in the patient that's really sick, I'll probably still give them bicarb. And in the ones that I'm thinking I might stave off some renal replacement, I'll still do it. But I'm not sure this completely backs that up as, oh, that's definitely evidence-based practice. And that's probably all I've got to say. Has anyone got any thoughts? Please feel free to totally disagree. How do I?
Yeah.
Happy?
Yeah, I was just going to ask. I can't actually remember giving bicarb to anybody at Glenford when I was a trainee. Does that happen?
I think I've seen it. Probably the only times I've seen it, if I'm honest, is in the sort of more post-elective surgery who are maybe a bit acidotic, but they're not in extremis. It's almost sort of normalising numbers, and a lot of them can come out a bit hypochloremic. So I think a few people looking at this have sort of said, I'd probably still use it in uremic. I'd use it in the non-raised anion gap. But beyond that, you know, this doesn't necessarily change their practice. So I've only seen it in like high chloride post-cardiac personally. I don't know about you, man.
Not very often, to be honest with you.
Yeah, it makes sense to give it if they've lost bicarb through diarrhea or whatever. That's fine. Otherwise, the only one I've only used it at the Royal for the multi-organ failure septic patients that are really acidotic, and hope that you can maybe get their pH a little bit better so you can make their inotropes work. But sometimes it works, sometimes it doesn't.
Yeah, and I don't think the answer is necessary, because in that population, I'm not sure that this necessarily gives the answer, but it probably suggests there's not necessarily, you know, obvious harm. But hopefully
that's reassuring.
I was going to talk about approach to refractory hypoxemia, but I thought actually it might be better to start with the approach to the hypoxic patient and start from there, and then we'll do another session about some of the other bits that we might be able to do. Okay, so here we go. Right, so I thought we'll start by classifying hypoxia and then some genuinely useful equations, because I think a lot of the equations that we learn are not that useful, but some of them can be. A bit of a chat about a structured approach to the hypoxic patient, or what I might potentially do, and then using a case to try and illustrate that, and hopefully it'll be a bit self-explanatory and hopefully useful. Okay, so bit of audience participation for this, so that includes you three. So there is a difference between hypoxia and hypoxemia, although they're commonly used interchangeably. But what is the difference? It includes people on the call that I can't see.
How you measure it as hypoxemia?
Sort of. Did you guys hear that?
No.
Okay.
It's hypoxemia when it's hypoxia when there's insufficient supply for the tissue, and hypoxemia when there's a low value.
Yeah, that's right. Yeah. So again, I don't know if you heard that because there's someone moving a cage outside, but essentially, hypoxemia is just a reduced partial pressure of oxygen in the blood. Okay, whereas hypoxia is a state of low tissue oxygenation. Okay, and they are used interchangeably, but they can occur one without the other. So it's worth bearing that in mind. Okay, so
Finn gets very upset about it if you're at the Royal.
yeah, it's
Get it wrong.
good pedantry. So in essence, if you think about classifying hypoxia, you've got to think about these two things. It's either that you've got an impaired oxygen delivery, or you've got impaired oxygen extraction. Okay, and again, these two things don't necessarily always happen together, and there are times when you do predominantly get one over the other, but it tends to be that we think, if you think about our septic patient, you've got predominantly an issue with impaired oxygen delivery. So the way that I would tend to think about it, and not everyone agrees with this, but I just think it's a nice way of structuring how you might think about it, is to use the oxygen delivery equation, which everyone learns to love and both hate as an anaesthetic trainee. And essentially, oxygen delivery, which is DO2, is equal to the cardiac output times the content, the oxygen content of arterial oxygen. Okay, and if you think about how much oxygen there is in arterial blood, it's a combination of that which is bound to hemoglobin and that which is dissolved in the solution. Okay, so we know that the majority, or the vast majority of oxygen, is carried bound to hemoglobin. Okay, whereas there's a very, very small amount in physiological conditions which is dissolved. And there's a law called Henry's Law for all of the FRCA people. What's Henry's Law? Amy's shaking her head. James is panicking. Anyone remember what Henry's Law is? Zoe, tell me what Henry's Law is.
Yeah, I can't remember anything. I had a brain injury, remember?
That's a terrible excuse. Henry's Law is essentially says that the amount of gas dissolved in a liquid is proportional to the partial pressure above that liquid. Okay, so it sort of explains why in you can increase oxygen to supra-physiological levels if you were in a hyperbaric oxygen chamber, for instance, because you're maximally increasing the partial pressure of oxygen, and therefore you can dissolve more in it. Okay, so under normal physiological conditions, the normal arterial oxygen content of blood is about per 100 mils of blood is about 20 mils, and under normal physiological conditions, the normal venous oxygen content is about 15 mils. So therefore, we've got about a 25% oxygen extraction physiologically. And when you get a mismatch between the amount of oxygen that you deliver and the amount of oxygen that's used, you end up under an anaerobic conditions, and therefore you have anaerobic metabolism, lactate generation, etc., etc. And that's one of the reasons why we can use lactate as a potential surrogate measure of poor tissue perfusion and therefore hypoxia. And this again is another graph that you'll learn to love. It essentially just shows you the correlation between oxygen consumption and oxygen delivery in both healthy patients and those who are critically ill. So, as we've mentioned, in the physiological conditions, you've got more than adequate oxygen delivery until you get to a critical point of oxygen delivery, which is around 250 mils, as we said. So under physiological conditions, you've got quite a large reserve, whereas when you're critically ill, the amount of oxygen you need goes up significantly, and therefore you've got far less wiggle room before you get to a critical DO2 and start having anaerobic metabolism. Okay, so we can't use our normal physiological maths in order to determine what a sick patient needs. Okay. All right, so if we break it down a bit further, and bear with me because this, I promise it will become useful in a second. These are essentially the bits that we're interested in, which we can impact on, and which we can think about from our causes of hypoxia, if you like. So the first thing is cardiac output. So that would be our circulatory or ischemic causes of hypoxia. We've got HB, so our anemic causes. We've got SATs and PO2, which are our hypoxic bits, and then we've got cytotoxic, which doesn't really fit. Okay, and we won't talk too much on that one. Okay. So if we think about hypoxia, which is what we're going to talk about for the rest of the chat, we can break it down into a few further bits. So we've either got a low FiO2, which sort of makes sense, hypo ventilation, diffusion limitation, shunt, and ventilation perfusion inequality. And these are the 5 bits that you can think of in terms of hypoxia. And we're going to go through those in turn, and hopefully this will become useful when we move on towards the end of the presentation. So hypoxia is pretty straightforward, isn't it? There's some more laws you can think of. Another one, Daltons Law. Anyone at the Royal? I saw Dr. Williams there.
They've turned the microphone off.
Shocking. Anyone remember Dalton's Law?
partial pressures, isn't it?
Yeah, that's right. So the total pressure exerted by a mixture of ideal gases in a fixed volume is equal to the sum of all the pressures of those gases. Okay, so it explains the principle that irrespective of where you are in the atmosphere, the proportion of oxygen in air is always around 20%, but the amount of oxygen in that air is dependent on the pressure. Okay, so at sea level, if we, for ease of maths, if we say there's 100 kilopascals, there's 21 kilopascals of oxygen. Whereas if you're up in the Himalayas, the amount of, although the percentage is the same, the physical amount of oxygen is significantly less. Okay, so low FiO2 causes of hypoxia are obviously very easy to fix because you just give oxygen. So that's quite a straightforward one to think about. The next one is hypoventilation. So this is where these equations that you learn as in your anaesthetic training can sometimes be helpful, working through them. Okay, and these causes of hypoventilation are things that you would probably assume. So you've got drug-induced things, so opiates, etc., neurological causes, alveolar hypoventilation syndrome, amongst others. Okay, and it's important to sort of recognise that if we look at the alveolar ventilation equation, if you half the amount of ventilation, you will double the amount of CO2. Okay, so the first fact is important, that in hypoventilatory causes of hypoxia, you will always have an increase in CO2 because you are lowering your amount of alveolar ventilation. The CO2 will go up, so you'll always have an increase in PCO2 if hypoventilation is the pure cause. And it will always decrease the oxygen unless you give supplemental oxygen. So this is sort of the times where people get caught out providing things like sedation, where you rely on SATs to monitor your ventilation. So if in people with normal lungs, if you stick an oxygen mask on and then use your SATs to mark how well they're ventilating, their CO2 could be in double figures, but their SATs are normal. But the key thing again with hypoventilatory hypoxia is that it's actually quite easy to fix. Okay. Anything else to say from that? So there's a few bits in this equation, but it's probably worth just having a read about it if you're an anaesthetic trainee, just to, and I'm sure you'll become very familiar with it, to be honest with you. Okay, so moving on, we've got diffusion limitation. So again, this is the oxygen cascade, another very useful graph that you need to learn to draw. If you get to draw still in the exams, I don't know if that still happens. But it's where there's a lack of equilibrium between alveolar PO2, determined by the alveolar gas equation, and capillary oxygen. So there's a diffusion restriction there, diffusion limitation. And these are all the things that we commonly see. So pulmonary fibrosis, interstitial pneumonias, connective tissue diseases, that kind of thing. Now they will cause other causes of hypoxia, and it's not easy to just pigeonhole all these things, but those are ones you might start to think of. There is also called exercise-induced hypoxemia, which is where you get where there's a diffusion limitation because of massive cardiac outputs that you can't maintain that diffusion gradient when you've got extremes of exercise that probably I will never ever reach, or probably very few of us ever will. But yeah, that is also a cause. And it's worth sort of a bit of revision. So James, you'll know this because you're a very clever guy. How long does it normally take a red blood cell to get through an alveolar capillary? Do you want to guess? You're looking at the screen, but the answer's not there.
2 seconds?
No. That should be more helpful. So it's normally about 0.75 a second, but they're fully saturated by the time they're about a third of the way along. So you've got quite a big redundancy there in terms of if you've got diffusion limitation, there's still time for that red blood cell to become fully oxygenated. So as with everything, there's a bit of redundancy built into the body. Okay. Happy? So last couple, so we've got shunt. So what's shunt, Amy? Or anyone? It's just they're here, so I'm picking on them. She claims she understood it last week. So shunt's blood that can basically is passed through the lungs without meeting the lungs. So it's blood that isn't oxygenated or isn't involved in gas exchange. And a right to left shunt is, yeah, as we said, it's blood passing into the systemic circulation that hasn't been ventilated. Okay, so it's either gone through non-ventilated segments of the lung, or not by the lungs at all, because obviously there are physiological shunts within the body, and you can calculate the degree of shunt from this really long equation here that we all had to learn, which is the shunt equation. It's that very famous, helpful question of derive the shunt equation, which is fantastic, but you can calculate it. So shunts can be anatomical, so i.e. the alveoli are completely bypassed, so we've got intracardiac shunts, so blood coming from the right side into the left without going through the lungs. Or there can be things like AVMs or things in hepatopulmonary syndromes, that kind of stuff. Okay. So facts about shunts that probably not the most interesting pub quiz facts really, but facts about shunts. They can't be abolished by giving 100% oxygen, which makes sense, doesn't it? Because if you are not ventilating that lung, if you're not gas exchanging that blood, you'll never improve it completely by giving 100% oxygen. But you've got to remember that some of the blood will get to the lungs, so by giving more oxygen, the PO2 will go up. It just won't go up as much as you think it will. But because of the solubility of CO2, it's likely that the CO2 is probably going to be normal, or at least low normal. Last one for the types of hypoxia. So we've got ventilation perfusion mismatches. Okay, so these are obviously really, really common, and they're probably responsible for. Sorry, everyone. Sorry, that was just Dr. Horst. So ventilation perfusion inequalities are the most common, and it probably explains most of the hypoxemia that we see in patients who come to intensive care, so COPDs, interstitial lung disease, PEs, that kind of thing. It's worth bearing in mind that you do get physiological ventilation perfusion mismatch in the lung, and it's again another thing that you'll learn as part of your FRCR FICM. And these are the reasons why you normally have an element of A gradient, okay, which you can calculate. Okay, so to illustrate this, I thought we'd talk about a case which is a patient that I was actually involved with a couple of years ago. So he's a 49-year-old guy, and the dates I've put on because they're sort of relevant. So a 49-year-old man, and towards the middle of February in 2019, he had a right pneumonectomy, pericardial patch, and a partial pleurectomy for a cancer. He had a pretty uneventful post-operative course, and about a week or so later, he was discharged home, essentially fit, normal, ready to go home, and then represented about 2 weeks later with a 1-week history of shortness of breath, although he was cardiovascularly stable, his temperature was essentially normal, and he was a bit tachypneic. Okay, so he was admitted to the thoracic ward, and he had this gas. So 80% oxygen, he's beta alkalotic, he's blew his CO2 down, he's hypoxemic, he's got a BICAR of 22, base excess of -3, and his lactate is essentially normal. So does anyone have a clue about what might be going on with this guy just from the history and what we've got on there? We do need a bit of audience participation. Think commonly, what are you going to expect? Post-op patient. Shortness of breath.
Guys at the Royal, you can turn the microphone on, you know.
Based on the date, I would expect possibly
COVID.
in March. Oh, wrong year. Too soon.
COVID was but a pipe dream, unfortunately.
You talked about the dates. Could be pneumonia.
Yeah, okay, yeah, so common things are common, aren't they? So PE and pneumonia are the things that are going to spring to mind. Post-op patient, a couple of weeks down the line, he's had a lung out, big operation, you think it's going to be that kind of thing. So if we work through it, so we've got our different causes of hypoxic hypoxia. So look, is it low FiO2? No. So last time I checked, the Glenfield wasn't in the Himalayas, so it's very unlikely to be low FiO2. So we can rule that one out pretty much immediately. Do we think it's hypoventilation? Why do you shake your head, Amy? Yeah, exactly. So his respiratory rate's 30 and he's managed to blow his CO2 down to 3 point something. So it's not hypoventilation. Diffusion limitation. So this is where some of these equations can come in useful. So we can use the A gradient to try and work these kind of things out. So if we look at the A gradient and calculate it, and you've got a rough estimate of what it should be, it's age over 4 plus 4. And what this allows us to do is to split the hypoxic causes of hypoxemia into whether it's hypoventilation and hypoxic gas mixture or all of the others. Okay, so we can rule out some of them immediately. And his was 64. Okay. And as we said, he was 49, age over 4 plus 4, so it's high, isn't it? Okay, this is his chest X-ray. What do people think about that?
Not normal.
Well, I would argue for someone who's had a pneumonectomy, that is probably normal, isn't it? So his right hemithorax is filled with fluid and it's got an air gas level, which is normal. But his left lung, importantly, looks completely normal, doesn't he? He's got a nice sharp costophrenic angle. There's no interstitial shadowing there at all. You can make out all his heart boards. There's no obvious pneumothorax. So to me, his left lung looks pretty normal, which is important.
It's not a normal chest X-ray, but
all right, fair enough. Okay, so I think that looking at his chest X-ray, we can get rid of diffusion limitation, okay, and we can probably also get rid of ventilation perfusion inequality because he doesn't have any of the issues we've already said from his gases previously. I think that it's not likely, so that only really leaves us with shunt. Okay, now for him, what he was being treated for on the ward was pneumonia. So he had a CTPA when he came in, which didn't show any PE. So again, goes against ventilation perfusion inequality, and it showed essentially a completely normal lung field on the left. So it's a bit odd why he would have a normal lung when he left, hasn't got a new pneumothorax PE or infection, and is now profoundly short of breath and hypoxemic. And ultimately, he's got something called this, so platypnea orthodeoxia syndrome. Anyone come across that? So he was quite interesting. So when you did everything that you would normally do in order to improve his oxygenation, so you give him oxygen, didn't really help that much. And then when you sat him up, which is what would normally help if you've got any kind of other pulmonary pathology, his oxygenation got worse when you sat him up. And it's essentially platypnea orthodox syndrome. You just work it out. It's shortness of breath and hypoxemia when you move from laying flat to sitting upright. And the reason being is that you get an increase in right to left atrial pressure, and it can exacerbate any kind of shunts that you have. So this is the gentleman's transthoracic echo, and if you take my word for it, this side, he's had a bubble study done. So all of this sort of snowstorm appearance in his right ventricle are little micro bubbles of air. So you shake up a 20 ml syringe of air, of saline, and with some air in it, and you agitate it, and then you inject it into a central vein, and you get this snowstorm appearance. And what you're looking for is whether you can see micro bubbles on the left side. And I think it's within 3 cardiac cycles, and there's a quote of the number of bubbles you should be able to see. But what you can actually see is bubbles coming across the intraatrial septum. So you've got a shunt, essentially, you've got a PFO. So why has this guy gone from being completely normal to now having a PFO? Yeah.
I don't know a huge amount about that surgery, but could it be? Is it a known complication of that?
Sort of.
Gone wrong.
Yeah. Yeah. So Amy was just saying, is it a known complication? Is it recognised? So nearly everyone having a pneumonectomy will have an echo before they have their surgery to make sure they don't have any kind of intracardiac shunts, because that can be a problem. And the reason that's a problem is when you remove half of the pulmonary vasculature, their pulmonary vascular resistance will go up. Okay, and what we suspected had happened in this chap is that he had his lung out, which will initially cause a high. It'll immediately increase pulmonary vascular resistance, but that will increase over time. And during the 2 weeks he was an outpatient, that pressure's gone up, and that's therefore opened up what was a previously sealed PFO, and he's ended up with a right to left shunt. So this caused lots of toing and froing with the cardiologists, because this guy was intubated on oxygen, and as soon as you laid him flat, his gases were fantastic. And then when you try to sit him up and extubate him, he then was profoundly hypoxemic. And eventually he went to cath lab and had a device closure of his PFO, and he was extubated and went home in a couple of days' time. So it completely resolved just by closing the shunt. So it's just quite an interesting, slightly different case of hypoxia and what you might find. We won't talk about those gases, but that was interesting. So this just pointed out why having an understanding of the oxyhemoglobin association curve is interesting, because this was a chap who had a massive PE, and it was essentially pointing out why, if you think, we've seen loads of patients with COVID whose PO2s are 8.5 and their SATs are in the 90s. This guy's SATs are only 54. Why is that? No. Anyone at the Royal? No, this is all about how the oxyhemoglobin, how the curve moves depending on hypercapnia and all the other kind of things that you'll see. So this guy's quite hypercapnic, so it shifted it over, and that's why you've now got oxygen stats that are low despite a high PO2. So it's just interesting. Anyway, so my approach to the management of these patients with hypoxia, I would think about it in this way, although I wouldn't really use the equation, just to think about things that we can clinically alter. So cardiac output, obviously we want to try and aim for what is essentially a normal or physiological cardiac output, so more than 2.2 litres index to body surface area. Hemoglobin's a sort of straightforward one, so in the majority of patients we aim for over 7. And then oxygen. So the first thing for anyone who's hypoxic is to give oxygen, and this sort of theory about CO2 retention and that kind of stuff isn't really an issue. I would tend to say if you're hypoxic, give oxygen, and then think about the other stuff. So think about the other causes and what potentially could be, and don't just try and pigeonhole everyone into the got pneumonia or a PE, because there are other things that cause it. And that was it essentially. So I thought next time we'll have a chat about some of the more refractory management of refractory hypoxemia, things we can talk about, oscillation and all that nonsense. And if anyone's got any questions.
Matt.
Yes, Ravi.
The PFO, I mean, is that common for patients with PFO to have this flat apnea or thodioxia syndrome?
Only if their right atrial pressures are higher than their left.
Okay.
So under physiological conditions, it doesn't happen because the right atrial pressures are always going to be lower. But anything that acutely increases their right atrial pressures, or they end up with the chronic cause, I don't know, they've got OSA or something like that. Okay. As their right atrial pressures become higher or approach the left atrial pressure, anything that then increases it further can cause it to flip the other way.
Yeah. So this is like a post-pneumonectomy thing that's happened in a patient who had a PFO that was sealed before.
Exactly. So he had an echo pre-operatively, which was normal, basically. It didn't show it, and it just became unmasked when his pulmonary pressures went up, and then over a period of time, it just only opened. Hence why he was fine afterwards initially, and then gradually over a couple of weeks, it got worse.
Thank you.
That's all right. Cool. So we don't have any teaching sessions lined up for next week, and then it's going to be Christmas. So I think the next one we'll be doing is in
7th of January.
7th of January. Yeah. So might get Ravi potentially to do that one.
Yeah, I think so.